Welcome everyone, and thank you to those joining us live and to those listening in afterwards. I'd also like to warmly welcome our guests today, whom I'll introduce shortly. I'm Donica Fitzgerald, moderator of today's event on behalf of the FIP Technology Forum, and I'm joined by my co-moderator, Professor Stephanie Huang, who leads the Precision Medicine Special Interest Group of the FIP Board of Pharmaceutical Sciences. And our speaker for today, Professor Iñaki Gutierrez Arbeluzea, former president and board of the director of Health Technology Assessment International, who I will introduce shortly. FIP's vision is a world where everyone benefits from access to safe, effective, quality and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences and education. We're pleased to be delivering this event, Precision Medicine, What Would It Cost?, the third episode of this FIP Precision Medicine webinar series. Just some quick announcements before we start. So this webinar is being recorded and live streamed via YouTube. The recording will be also made available on our website, www.events.fip.org. You may ask questions using the question box provided. You are also welcome to provide feedback to webinars@fip.org. You can become a member of FIP at www.fip.org/membership registration. So precision medicine is an innovative data-driven approach to tailoring disease prevention and treatment that takes into account differences in people's genetics, environments, and lifestyles. With the era of precision medicine on the horizon, accompanied by a rapidly evolving technological landscape, it has never been more important for the pharmaceutical community, from clinical practice to research and policy, to reflect on its role and engage in its development and implementation. Our aim with this series of webinars, which we started last year, is to bring the pharmaceutical community closer to the precision medicine field and to subsequently identify gaps and opportunities for pharmacists and pharmaceutical scientists to fill through research and clinical practice development. This is the third webinar of the series. In the first webinar in April, The Current Status, we discussed the current state of the precision medicine in practice, the technologies utilized in precision medicine deployment, and the remaining challenges and opportunities. The second webinar in October, Where is the Technology Heading?, highlighted some key technological advancements likely to shape the future of precision medicine. The third webinar, What Will It Cost?, which is today, will aim to discuss a major hurdle to the implementation of precision medicine, its cost, and what is needed to overcome this. And we may also continue with further webinars in the future. As a quick recap of the previous webinars of the series, in Precision Medicine, The Current Status, we introduced the needs, goals, and principles of precision medicine, along with some examples of current diseases, from cancer treatment stratification to pharmacogenetic decision support systems. We also touched on limitations and opportunities for further development, joined by Dr. Mark Dunnenberger and Einar Moltzen of the Clinical Pharmacogenetics Implementation Consortium and the International Consortium of Personalized Medicine, respectively. We learned about international coordination efforts for advancing the clinical implementation of precision medicine. In the second Precision Medicine webinar, Where is the Technology Heading?, we had an overview of the ongoing technological advances driving the evolution of precision medicine. We gained insights into the surge in open source software and computational tools for modern biology with Dr. Wolfgang Huber from the European Molecular Biology Laboratory and also from the Bioconductor Project. And we also learned about high-throughput drug screening technologies for clinical translation with Professor Christoph Merten from the Swiss Federal Institute of Technology in Lausanne. The learning objectives of today's webinar are the impact of precision medicine advancements on health technology assessment, the economic arguments for and against precision medicine, and international coordination in health technology assessment policies for precision medicine. So with that now, I'm very happy to introduce our speaker today, Professor Iñaki Gutierrez Arbeluzea. So he has a very extended biography and many roles. So this is something that we cannot fit into one introduction. But he's currently Director of Innovation at the Basque Foundation for Health Innovation and Research, coordinator of OSTEBA, the Basque Office for Health Technology Assessment, has collaborated and advised on several EU and Spanish health technology assessment projects, and also has served on the board of directors and secretary of the International Society Health Technology Assessment International. He's also been the chairman of Euroscan International Network, spent time as associate professor at the School of Nursing at Osakideza Basque Health Service. Was a member of the international scientific community of the Health Innovation Awards of the NHS Northwest in the UK. And he's member and coordinator of the Spanish Task Force for Genomics and Public Health. He's collaborated with WHO Europe as an expert advisor and evaluator on the program of medical devices for countries with limited resources, and has also advised several of these different countries for the HTA strategy. He served as co-chair of the ISPC of Health Technology Assessment International Tokyo 2017, and is member of the technical advisory group that assesses WHO and HTA and universal health coverage. And he's been an author of more than 70 peer-reviewed articles, 50 monographies, and 4 clinical practice guidelines, 5 books and 4 book chapters. He's also served as associate editor on Frontiers in Pharmacology and Health Outcomes Research and Hint Journals, and a member of the editorial board of UFA and the IGTHC journals. And with that, I'm very, very happy to hand over to Professor Iñaki, who will now give us a very interesting talk on this topic.
Hope so, Donaka, and thank you very much for inviting me, and thank you very much also to the International Pharmaceutical Federation for giving me the opportunity to talk about this tremendous topic that is also hitting all our systems. And I hope that I will give some kind of tips and some clarity on what is going on and how we can try to face the problem. I will take the control of the slides, I think. First of all, I will talk about the impact of precision medicine advancements on health technology assessment, and I will be at the very beginning talking about what health technology assessment means and how it is applied in different parts of the world. Slide disclaimer. So this first of all, that the visions and motivation of these presentations belong to me, and in no case do they represent those of organizations such as Health Technology Assessment International, Euroscan, INATA, Osteva, BioF, or Reddit, with which I collaborate or am a member of. And the only conflict of interest that affects, in principle, this presentation is that I have a strong belief that the public health system and universal health coverage is the fundamental basis of for a better health outcomes and a better society. So having said that, let's go to what we are talking about today. First of all, I will talk about decisions-making processes on health and which are the domains that they consider when we are making those decisions. Health technology assessment definitions along the years and how it has been applied in recently. Main reasons behind HTA use, how that can be applicable to personalized medicine, and which are the challenges and opportunities, and also which are the main enablers or barriers to introduce precision medicine in our systems. That it should be one of the aims, because we wanted to have the best management option to our clients that finally they are the patients. So what about health technology? I don't know if you are. I've seen some of you, and I know that you, not all of you, you are coming from, as it is my case, you are not coming from, I would say, English-speaking countries. And one of the problems that we have, it is, first of all, the definition of health technology. At least in my case, it is when we are talking about health technologies, and that is in Basque or in Spanish or in Italian, normal languages that I use, it is that it is related to a gadget. Probably if you ask someone in the street and around what health technology means, probably well, they will say this is a medical device. But in reality, if we go to English language, we need to say that health technology is an intervention developed to prevent, diagnose, or treat medical conditions, promote health, provide rehabilitation, or organize healthcare delivery. And the intervention can be a test, a device, a medicine, a vaccine, but also a procedure, a program, or a system. So in principle, what we are talking about when we are talking about health technology is we are talking about solutions to the problems that we have. So it is trying to answer the questions that we have in the systems. Then if we go to the decisions that are made in healthcare systems, we need to go step by step and going up the stairs. And those are mainly the decisions that are made. On the one side, market access. On the second side is prescription. On the third side is provision. And then it is decisions of coverage and reimbursement. So it is finally being applicable for a good wide range of people. When we talk about market access, and it is what regulators do, we talk about, in principle, can it work? And regulators think about two major domains, safety and efficacy. If the technology is sufficiently safe and it is sufficiently efficacious, and all the balance between safety and efficacy, it is in favor of efficacy, and that deserves an introduction in the market. Then we go to prescription. That is what professionals do. And what professionals do, it is, does it work? So can I apply those technologies to my patients or my single patient? And what they have been practicing, at least in the last 40, 50 years, it is what has been called the paradigm of evidence-based healthcare. And what they wanted to, it is about, obviously, to continue looking at safety, but what they want to do, it is to look at effectiveness. That is, in reality, that can be applicable to the patient that I have. And may I prescribe that? The third thing, it is provision. So it is that means we are talking in a healthcare system, and we need to provide to a wider range of population. And then what we ask it is, does it work proper than others? So when we have more than one alternative, and what we do it is compare between the different alternatives that we have in terms of providing the best solution possible. And finally, when we are talking about decisions of coverage and reimbursement, that is what HTA do. What we ask for it is it worth it? And what we combine it is safety, efficacy, but also effectiveness, comparative effectiveness, but also other aspects that are related to organizational, economic, legal, socio-cultural, political, ethical, and currently also environmental aspects. So what is health technology assessment? In the early definitions, I'm referring to one of the founders of the and the one that started talking about health technology assessment, that was working for technology assessment in the US. Because we need to say that that technology assessment started in the US, and that is David Banta. In the HTA glossary, it appeared that the HTA was the systematic evaluation of the properties and effects of a health technology, addressing the direct and intended effects of this technology, as well as the indirect and unintended consequences, and aim mainly at informing decision-making regarding health technologies. And if we go about the definition by Banta in 1993, so currently 30 years ago, technology assessment is a form of policy research that examines short and long-term social consequences, for example, societal, economic, ethical, legal, of the application of technology. And the goal of technology assessment is to provide policymakers with information on policy alternatives. So we are not making decisions. What we do is to put on the plate and put on the table information around the different domains and the different aspects to make decisions easier to those that need to make decisions. And it can be applied at the micro, at the meso, at the macro level. But let's go further. What is the new HTA definition? This was established in only three years ago in 2020 when it was published, and it was a combination of two institutions. On the one side, the INATA, the International Network of Agencies for Health Technology Assessment, and on the other side, Health Technology Assessment International, that is the international society that comprises all that do HTA. In that new definition, it says it is a multidisciplinary process. Pharmaceuticals are accepted for sure, and those that are pharmaceuticals, not pharmaceutics, are accepted. So you that are encountering and also using pharmaceutics, and you are working in pharmacies, you are more than welcome. In fact, in most of the HTA units, there are pharmacists. And it is a multidisciplinary process that uses explicit methods to determine the value of a health technology at different points in its life cycle. It started another concept that in the past, HTA was applied to say yes or no to not to the market access in terms of regulation, but to the access to the healthcare systems. But nowadays, there are decisions that are supported by information generated by HTA doers that are related to once the technology has been applied, what happens with variability in practice. Once the technology is obsolete, if we have information sufficient in terms of doing this investment, or those that are starting designing a technology, a drug, a vaccine, a program, or whatever, they could talk with HTA doers in terms of which could be the best pathway to create that technology, and which in reality are the needs of the systems and which are the gaps. And the purpose it is to inform decision making in order to promote an equitable, efficient, and high quality health system. If we go to that in reality, it is that the process is formal, systematic, and transparent, and uses state-of-the-art methods to consider the best available evidence. So it is quite well rooted in all the concept that is evidence-based medicine. And also the dimensions of value for a health technology may be assessed by examining the intended and unintended consequences. So it is quite aligned with the previous definition. But one of the things that is said also, it is the dimensions include clinical effectiveness, safety, cost and economic implications, ethical, social, cultural and legal issues, organizational, and one of the things that has been added as dimension and domain to be bear in mind, it is environmental aspects. And the overall value might vary depending on the perspective taken, the stakeholders involved, and the decision context. So we can say that one technology could be the best one in one country, and perhaps it is not tailored to the needs and the gaps that could appear in other country. Also, as I said before, HTA can be applied at different points of the life cycle of a health technology. In example, or for example, pre-market, during market approval, post-market, and through to the disinvestment of a health technology. HTA and its dimensions. Also, HTA related to three main domains or dimensions. A cognitive dimension, that is retrieving relevant knowledge for decision making. A normative dimension, that is creating and promoting dialogue that supports decision making. And the third one, it is the pragmatic dimension, that is establishing a process that facilitates and supports decision. What is not HTA? HTA is not evidence-based medicine, but it uses evidence-based medicine. HTA is not just a systematic review or a meta-analysis, but we do systematic reviews and we do meta-analysis in terms of supporting decisions. It is not just health economics. So some people think still that health technology assessment is pharmacoeconomics. Pharmacoeconomics is a part of HTA world and one of the domains that we use in terms of providing information for decision making. And HTA is not just an organizational, ethical, legal, social, environmental analysis, and it's not decision making. We are not making decisions. What is more? When we did an analysis, and those are 3 articles that we published in the International Journal of Technology Assessment in Healthcare about the issues, the motives, the enablers, and barriers of using health technology assessment, we understood, and once we did it, that it did not differ between high-income countries and low- and middle-income countries. In fact, if we go to the first 3 aim or motive in order to implement HTA activities in one country, the first 3 ones, so it is to support decision making in healthcare, credibility, transparency, and accountability, or to achieve better quality of health services, they were the same in high income and low and middle income countries. They only differ in the last 2. On the one side, it is to reduce and or control healthcare cost, that was in low and middle income countries. But also in high-income countries was sustainability of the health system. And one of the things that was important in high-income countries was the interest of the managers to produce a credible process. So in principle, transparency and accountability. If we go to the enablers, one of the challenges, especially in low and middle income countries in comparison to high income countries. In high income countries, the problem was not human resources, it was financial resources. And the second enabler for HTA models was human resources. But the main problem in low and middle income countries was human resources. And also, obviously, it is existing good practices, an example from other countries that was common. And in the case of low and middle income countries, it was understanding the local needs and setting priorities. One of the main challenges, as I said before, it is that we are used to answer questions that come from high income countries in order to answer or we use technologies and we use answers that we use to answer questions in high income countries, and we translate those to low and middle income countries, which is in most of the cases an error, because the priorities differ, the characteristics of the countries differ, the healthcare systems differ, the capacity of the workforce differ, and so on. So it is one of the challenges and enablers in order to introduce HTA in low and middle income countries was local needs and setting priorities. And finally, assisting international networking and support and collaboration. So one of the demands of low and middle income countries was also collaboration and networking. Another thing, and this was part of my disclaimer, and I was talking about universal health coverage. And if we go to universal health coverage, then nowadays they are the objectives of the millennium, and that has been under the umbrella of United Nations, and we are talking about the objectives of sustainability of the millennium, and that is one of the approaches in terms of diminishing the effects that we are having so far with climate change and other inequalities in the world. It is that in the area of health, what they promoted is universal health coverage goals, and how HTA can contribute to that. In fact, United Nations and World Health Organization says that the health technology assessment definitively is a tool in order to reach to the universal health coverage goals. And if we go to the goals in terms of universal health coverage, that is access to safe, effective, quality, and affordable essential medicines and vaccines for all, I would add health technologies, so not just essential medicines and vaccines, but other type of technologies. It is quite aligned with the HTA definition. That was the purpose. It is to inform decision making to promote an equitable, efficient, and high quality healthcare system. So in this regard, we can say that health technology assessment and universal health coverage or health technology assessment can be a tool for reaching to the goals of universal health coverage. In fact, if we go to the 7 principles that drive universal health coverage, that are essential benefit package design should be data-driven and evidence-based, quite aligned with HTA. Essential benefit package design should be, in principle, open and transparent. That is aligned also with the methods that we have mentioned so far. Essential benefit package design should be based on national values and clearly defined criteria. I think it is the same. So it is establishing priorities. This is part of the methods that we use in health technology assessment. Or essential benefit package design should respect the difference between assessment, appraisal, and decision. We have said that we don't make decisions. We help in the area of assessment and appraisal. Also, essential benefit package design should be impartial, aiming for universality, and that is part of the definition that we have seen in health technology assessment, and also democratic and inclusive with public involvement. It is including the stakeholder is part of the methods that we use. And finally, essential benefit package design should be linked to robust financing mechanisms, and we are doing also economic evaluations in terms of guaranteeing that. HTA and the life cycle, as we have said before, HTA can be applied at different points in the life cycle, and there are decisions that are made that are crucial in terms of introducing the best technologies possible in order to answer the gaps and the needs that we have in systems. Here you can have the decisions that are made. So mainly early dialogue when it is produced research and development, market authorization, so it is helping regulators in terms of introducing the best technologies to the market, investment, so it is granting health provision, and we are introducing the technologies that are in need in each of the health systems, and finally exclusion from provision, so this investment on the basis of the information that grants that any other technology that we have, it is better than the one that we are using right now. So one of the principles that I think it is important and that is applicable to precision medicine, and as I will continue, it is that context matters. You need to know your health system and its needs. You need to identify solutions to these needs, so the answers. You need to identify main stakeholders that are involved and their importance and hear them. One of the things that we are not doing in our systems, it is to hear patients and professionals in order to use the best technologies possible. Who is the customer or customers, and which are the customers' characteristics and how you can fit their needs. Those are the principles in making the best decision for each of the contexts that we are applying technologies. And which are the domains? There are domains that are related to, or they could be quite common in each countries around the world. Those are what we call the core domains. So they are related to the technology, and that is safety, the clinical effectiveness, and the characteristics of the technology. But there are some others that are specific. So when we are saying economic evaluation of a technology, that is context dependent, that is country dependent, that is professionals dependent, and that is citizens dependent. The ethical aspects, the ethical approaches to healthcare and the ethical approaches to health technologies could differ from country to country and from region to region. Organizational aspects, they depend on how healthcare systems are organized, and some solutions that could be the best for one country could be not the best solution for another country, and that depends also on organizational aspects or acceptance that could be debatable in some countries, and those are social aspects, or legal frameworks that allows the introduction of certain technologies in one country, but they do not allow the introduction of other technologies in other countries. So precision medicine, and someone was asking, well, this guy was talking about precision medicine, and we have gone from some slides and we haven't talked about precision medicine at all. I found this book in Porto, in Portugal, and it's a funny book from the very beginning of the 20th century. I think it was published in 1907, and they were talking about I don't know if you know Portuguese, but what is said, it is a saúde individual, so that means that is precision medicine or personalized medicine. So, and in the very beginning of the 20th century, already in some countries and already professionals, and I think it is one of the main themes that professionals try to do since medicine and pharmacy and other medical and medical related or medicine related specialties were created. They talk about the best solution for the individual patient. So it is precision medicine, according to Medline Plus in 2022. I'm not inventing the wheel. It is an emerging approach to disease treatment and prevention that takes into account individual variability in each person's genes, environment, and lifestyle. Already, physicians at the very beginning of the 20th century, they were thinking about perhaps not genes, but they were thinking about the environment and the lifestyle, and they took into account genes by comparing families and looking at what happened to the parents of the children, the cousins, and so on. So the only thing that differs is that nowadays we have more and more information. So precision medicine versus personalized. And I'm not going to go in depth on the debate, but at least according to Medline Plus, precision medicine and personalized medicine, according to the National Institutes of Health, they say that personalized medicine is an older term with a similar meaning to precision medicine. And there is a misinterpretation of personalized to imply that unique treatments and preventions were being developed for each person, which in reality we are far from achieving right now. Perhaps in the future we will do that, but I don't think we are that far. So perhaps it is more precise to talk about precision medicine and not personalized medicine. In precision medicine, the focus is on identifying which approaches will be effective for patients based on genetic, environmental, and lifestyle factors. Also, there has been a shift in paradigm, especially for those that are producing technologies. And this was a very interesting article that was published in the Canadian Medical Association Journal some years ago, that they were talking about the changing paradigm from blockbusters to niche busters, and justifying current prices of drugs and other health technologies. And they were saying, instead, where we are going and where are we going. So it is in the article they said instead pharmaceutical companies should focus on increasing the efficacy of their products by developing them for smaller groups using a parallel model of drug diagnostics. And it was at the very beginning of the 21st century, so it was more or less 20 years ago. And developing companion diagnostic tests for the new products, companies could stratify patients based on their genetic predisposition to respond to these therapies. And this could create a more streamlined drug development process with less trial and error and higher success rates, paving the way for personalized or layered medicine. It is a trend that several pharmaceutical firms say they are following. So that was very beginning of 21st century. Nowadays, it is a reality. The promise of personalized healthcare, the P4 paradigm, predictive, preventive, personalized, and participatory. What is more? When we are talking about that, we are talking about medicine studies, the risk factors, predispositions, and genetic susceptibilities that exist before issues arise by the use of genetic testing and genome sequencing, technologies that have evolved in the last decade. Preventive, because medicine uses the knowledge of the risk factors learned from predictive medicine to change a person's behavior. And nowadays we can talk in reality to real preventive interventions, because we know what is happening when we change some of the people, some of the citizens, some of the patients' behavior, and how it is translated into health. Personalized medicine, in which each individual will respond differently to treatments, and participatory medicine, in which the patient and doctor relationship will become more interactive. So we are talking in reality about interaction and stakeholders development and stakeholders involvement, sorry. So as we have seen, it is not just genome. We need clinical data, good clinical data. We need genomic data. We need good genomic data, which I think it is easier to achieve. But we need also environmental data and lifestyle, which is in most of the cases is more complicated. In some of the cases, lifestyle could be at least recorded, but environmental data in many occasions is difficult to achieve, and it's difficult to assign to individuals and make that a meaning in terms of pathology. So what has this changed? Well, first of all, here you can see how many of the new molecular entities approved by FDA were personalized in 2005. 5%. In 2016, 27%, and in 2018, 48%, 42% of the new molecular entities approved by FDA were personalized. And which is the reason behind? Well, I will go in depth on that. First of all, precision medicine, it is just the hidden history behind the interpretation of confidence intervals. I don't know how many of you have studied also clinical epidemiology, and we were struggled with statistics and about the confidence intervals and which was the meaning of that. In principle, precision medicine, it is the hidden history behind the interpretation of confidence intervals, because if we could have a tailored treatment to each of the patients that we have, probably confidence intervals would be not needed. And probably, or if we could talk about a stratified analysis of the impact of technologies in terms of outcomes, probably the intervals will be narrower, and narrower. So it is precision medicine is the hidden history behind that interpretation. Previous barriers in 2000. First of all, lack of disruptive technology. It was huge investment required. The patents policies was a main issue. Cost of genome sequencing was one of the main challenges. Data storage and data combination, something that is nowadays quite easy going, and we know nowadays the capacity that big data storage companies have. I wouldn't mention some of those, but some of those it is the one that is carrying most of the codes to our houses. And they have a huge capacity in terms of data storage, and also misconceptions of professionals and citizens around the precision medicine. Furthermore, some barriers have been surpassed. Generation of new technologies, investment has been produced. It has been a huge reduced cost of genome sequencing, and also there have been huge advances in terms of data storage and data combination. we are talking about that in most health systems are electronic medical records, and they can be combined. This has been a massive change in terms of promoting precision medicine. There have been projects in the European Union like Eden or Darwin in terms of collecting data and combining data and make data available even around real world evidence and so on. There have been combinations of different initiatives in terms of creating standards, in terms of combining data, in terms of allowing precision medicine, like the standard of OMOP that is creating an interoperable data standard, or tools that can combine even when electronic medical records are produced with different systems, with different technologies and so on. There are nowadays technologies that allow us to make those combinations interoperable and to combine data from different systems and different sources. Furthermore, this is a trend in genome sequencing cost. I still remember that how much money we invest when it was the start of the genome program with James D. Watson, and it was more than 10 million euros was the cost of a genome to be sequencing at the very beginning of the 21st century. And nowadays we are talking about whole genome sequencing and next generation sequencing around $350 and perhaps less. And this is the trend in genome sequencing cost, and this is the trends in genome in cost per human genome. And we can see which has been undeniably which has been the cost of that we currently are paying, and probably that will drop down with the new technologies that we are having. So what has not changed? What has not changed? It is that it is not just genome, as we have said before. We need clinical data, we need environmental data, and we need lifestyle data. So it's still the Lalonde paradigm around how we behave and how we are going to develop a pathology. It is pretty much related to genetics, but also it is pretty much related to other type of things. In fact, in most of the pathologies, genetics explain 20%. 10% it is related to medicine and how we obtain outcomes. And 70% it is related to lifestyle and environment, around 50% lifestyle and 20%, well, it depends on where we live, but and that can change, but more or less the percentage is at that high. Also, the healthcare systems have changed along the years from inpatient care to systems biology. And nowadays we can talk about wealth promotion, personalized healthcare, citizen-centric integration of care, and citizen stratified by risk, because we have done the transition between the 80s to the 2020 and on with the creation of inpatient care, outpatient care, chronic disease care, stratified care, in-house care, and many other things. So the healthcare systems have evolved in terms of reaching to the point in which we are right now. And how that HTA could be applicable in the case of personalized or precision healthcare. Once again, we need to use the domains that are included under the definition. So it is safety, clinical effectiveness, cost and economic evaluation, ethical issues. Ethical issues, organizational aspects, social aspects, legal aspects, and environmental issues. I will go in depth with each of those one by one. So what happens to safety and precision medicine? First of all, we need to say that when we introduce precision medicine, and that is one of the claims of precision medicine, is that we increase the safety profile by tailoring indications. So that means that we are applying the technologies that were supposed to be the best ones for the individuals. Also, it could create a reassessment of existing drugs and other technologies. We have talked about the confidence intervals, and we have said that in some of the cases, there are patients that have no effect on the treatment that we are applying, or even we have unintended consequences because we are applying those treatments and they are creating more harm than good. So it could be that we can make some kind of post-marketing follow-up, and in fact, we are prescribing some treatments because we are seeing that in some of the patients in which we are applying the standard of care, we are seeing that those treatments, they are not applicable. Also, it is a chance for disinvestment in certain indications. Also, we can redefine existing regulatory policies. And in fact, if you go to what we are seeing with pharmaceuticals and how many pharmaceuticals nowadays they are approved on the basis of precision medicine, and you have seen that in the last year, FDA have approved 42% of the drugs based on precision medicine and around biomarkers. So it is the need of inclusion of biomarkers that support indication. And also, there has been a way to minimize the possible impact on individuals, safety concerns, on service providers, legal concerns, and health technology manufacturers, legal concerns, and delay in the approval of new treatments. So once again, precision medicine has been helpful in terms of safety, or that in principle. Also, what about cell and gene therapies when we have still many uncertainties around the effectiveness and the safety at the mid-long term. We don't know how to measure them in general, in which period. That is one of the challenges, and that it will be applicable to effectiveness and that will be applicable to cost. How many treatments and which is the continuity and discontinuity of some of those treatments that we are applying as precision medicine. How they will interact with other factors, in-house versus commercial solutions. So if we can build, and nowadays we can even develop some of the precision medicine solutions in-house. So in some hospitals, as it happens, for example, with CAR-Ts and some others, and that makes also other challenges in terms of safety profile. What about clinical effectiveness? In principle, precision medicine also increases the clinical effectiveness. We can have also a shift and a change in the randomized controlled trials paradigm for drug approval, because we are thinking about reducing the intervals, perhaps reducing the numbers that we need in terms of sample, in terms of creating sufficient certainty. Also, we can talk about surrogated results, and nowadays perhaps using diagnostic technologies could help us also and having more certainties about that. Also, it is a chance for preventive measures that in the past perhaps we had no clues on how preventive interventions or preventive activities could go for certain individuals, and nowadays that we have more clues, more I would say certainties around how they could, and how they are correlated with that, and we have reasons behind and argues to justify that. And also there is a need of combination of results, clinical, environmental, and genomic. So that creates attention because we need data, and we need good data in terms of creating that. Furthermore, if we go to clinical effectiveness of cell or gene-based therapies, in principle, we have an increase of the clinical effectiveness. Most of those, they have been considered as drugs. Also, I suppose that in your field, it has created also a mess, because you need to not just to discuss about pharmaceuticals, but also about cell and gene therapies. And also, which are the outcomes and how they will be measured. If that will be applied to single patient measures, and once again, in which period we need to demonstrate the value, and if that will be sustainable on time. In some occasions, we are thinking about, well, that will solve the problem, but we have still a short period of time in which we are demonstrating effectiveness, but we don't know what will happen in the mid-long term with those technologies and the applicability of them. Furthermore, and here's the elephant in the room, and also the issue of cost. Someone is claiming that there is a reduction in cost because we are creating more precise treatments. So we are spending the money in the place that we need to spend on. In reality, what I've seen it is that with new solutions and we need new technologies, I haven't seen a reduction in the budget, to be honest. So it is a huge problem because of the prices that we are seeing, especially with the new solutions. The other thing it has created also another tension, that is who pays for diagnosis. If they are the systems, if they are the patients, if they need to be included in the regulatory processes, and it is mandatory in terms of providing the access to the prescription, and it is related to the indication. So regulatory processes are also a challenge in terms that they are defining indications, and they are defining indications that require diagnostics before the prescription. Also, how they will be managed, the reimbursement policies, and which will be the financial incentives for citizens. For example, especially if we are promoting precision medicine-based preventive activities in which citizens will change their behavior, they will change their lifestyle, they could even change the place in which they live, or where they live. And how will be some kind incentivize the active role of the citizen in her own health and wealth? And also, when we are doing, in most cases, a co-development of drugs and genome-based diagnostics that help to tightly define indications, if that will be required for approval, and that will be also an incentive for reimbursement or higher price. Which are the economic issues on gene and cell therapies, and also precision therapies? It is which the fair price is. Nowadays, we are using new technologies that are more precise in some occasions, that they are aiming to cure, which was not in most of the pathologies and the paradigms, that they are too expensive and systems would not be able to afford and will take risks. So one of the issues, and I will refer to that, which are the two axes in terms of making decisions, and one axis it is related to an uncertainty on evidence, but the other axis it is uncertainty on cost. So if they are too expensive, systems are not going to afford them, and we are not going to have sufficient budget in covering them. But if they are too cheap, and it won't be worth developing, so there won't be any kind of incentive to manufacturers and companies in terms of developing them. I think it is crucial to have some kind of public-private partnership in terms of obtaining a fair price according to the value that we are in principle achieving. And one of the things it is, how will systems pay for this, and in which period? We are talking about, and I will refer a little bit about that in future slides, but we are talking nowadays about purchasing drugs, purchasing medical devices, purchasing or even promoting preventive measures, and being paid in a period like a mortgage, and that creates also tensions from the procurement systems, because they are not accustomed to that way of doing. And probably one of the things that will be neat, and in principle we are doing, because of the uncertainty that we have around cost, it is probably having some kind of risk sharing schemes. Another thing, it is the data in the cloud. So another elephant in the room, that is, we require the combination of data from different sources, and probably that cannot be doable without having data on cloud. Nowadays, there are certain good initiatives in this regard that have reduced some kind of tensions in so far. And they have been quite successful. I've mentioned a couple of, one is Darwin, and the other one is Eden Odyssey. That what they are creating, it is no need for data in the cloud, but need for meta-analysis of results that are, and data could be federated in terms of making better decisions. Ethical issues. So first of all, it is the change in the concept of health and disease. So this we have changed the prediction, and that is in favor, in principle, to professionals that they were in need to have well, decisions based on not full certainty on the best treatment option, sufficient understanding to justify population-based genome sequencing, the ownership of the information, who is the owner of the information, and in principle it should be, and it needs to continue being the patient and the citizens. The patient's understanding and patient's role. So it is that nowadays they need to understand that they are more crucial in terms of making decisions, because there is more certainty, and as such, they could decide on which the best solution could be for them. Other type of things like human dignity, stigmatization, and discrimination because of some populations that we could know that because of the genomic data and because of lifestyle, because of environment, they could develop some pathologies and also that could refer to discrimination. Also accessibility to data and accessibility to treatments, and also human integrity that should also be considered, as it could affect moral convictions, preferences, and commitments, including the right not to be tested or diagnosed. So another thing that we haven't heard about when considering precision medicine, it is that perhaps there could be some people that they don't want to know what is going to happen to them when we are talking about prediction, or they don't want to know what is going to happen with the treatments that we are promoting, or the treatments that we are prescribing to them. So another thing is the right not to be tested or diagnosed, or the right not to know. If we apply to gene and cell therapy, this in most European countries, bone marrow or blood cell donors do not receive any economic compensation. It is forbidden by law. But there are other countries in which bone marrow or blood cell donors receive compensation. So it is how to obtain cells mostly for public biobanks and use them to make business. That is another tricky thing. Does the management of those cells genes justify the cost and enable it to patent? Another thing that we are nowadays under discussion because of the CAR-Ts. So it is a huge problem. And which are the limits of commercial use of those products when they are created for example, in public headquarters, or in public hospitals, or in public healthcare systems? Organizational aspects. So it is a huge emphasis on wellness and disease prevention, a change in health services paradigm, especially primary care and public health play an outstanding role, because we will need to integrate all those aspects related to lifestyle and environment, and that resides in primary care and public health. So this lifestyle in most cases is recorded by primary care physicians, and environmental issues and environmental aspects and socioeconomic conditions mostly relate to public health directorates or public health departments. So they will need to play an outstanding role in this regard. Also, that is a change in work and patient flow process, and patients empowered and self-decision making will become possible, because there will be time dedicated to patients carefully rescheduled. Staff training on genomics, management of genomic information and its consequences, and the acquisition of self-decision making skills that will be also important in terms of having fair decisions as a whole. Also, providers' inclusion of health literacy, that will be important, like personalized healthcare and stratification of patients, centralization of diagnostic services, and decentralization of the decision-making processes. So probably with the technology that we have, we can make those decisions on trying to personalize healthcare and stratification of patients and decentralize the decision-making process with information that we could have from those centralized diagnostic services. And also there will be funds for personal data protection and supercomputing systems, and there will be also that the patients and public health systems will be once again empowered. So it is precision medicine. Also, it is. I think it is an opportunity. Also, if we go to organizational aspects and gene therapy, so which will be the role of health providers and that of manufacturers? This is one of the things that we are discussing right now. If biomarkers are produced by health systems and companies, what they are producing, it is drugs or medical devices, what will happen to that? Because they will require a combination of those. We are not talking about single technologies. We are talking about combination of technologies, to which extent extraction of cells will be performed by systems, and processing will be assumed by systems, and then therapy will be once again on systems' hands or on companies' hands. So those are things that we need to discuss also. Furthermore, social aspects. We have said empowerment and increasing autonomy of patients and their relatives. I think it is crucial, but also a stigmatization of certain populations according to genomic, clinical, and environmental data, and that also creates attention on systems. Current technology makes internationalization of the data possible. We have talked about the initiatives about federated data and the combination of data. Sorry. Also, there are nowadays policies to promote implementation of personalized health services, like people and subgroups involved, the support required, and the cost involved, and also people's reaction for and against such services. So this qualitative and quantitative research. So it will be also important. And also finally the legal aspects that are also crucial. The maintenance of citizens' autonomy, the legal liability. Who is liable for these new treatments? It is still the producer, or will be a combination of the producer and the system. The protection of the information generated, and because that requires the combination of data. The professional ethical guidelines become statutes or mandatory guidelines. The lack of harmonization of laws in different contexts, when, for example, diagnosis could be done in one place and then the treatment could be done in another. So also the patient's autonomy, the collection of biological and clinical data and data protection are regulated by law in Europe, at least. So those things are also tremendous. Or the legal barriers concerning different reimbursement and pricing policies in the different parts of the world, and the implementation of personalized healthcare services and products resulting from inequities and unequal access to them. Also the advertising, so is how that can be advertised, and also the free movement of services should be harmonized in terms of avoiding citizens' misconceptions and unlawful practices. More than that, why, and I'm going to, once we have developed all those aspects related to precision medicine and in accordance to the domains that should be under the umbrella of the analysis of HTA. So how are decisions made? The decisions are made on trust, and one of the things that are systems when approaching to the precision medicine is that they want trust. So to be effective, it is crucial, and having trust impacts health behaviors and outcomes such as vaccine acceptance, treatment adherence, and patient satisfaction. And that is applicable to precision medicine. In principle, precision medicine could help in terms of creating trust on those things that we are going to promote. Also, that could create also a reduction in or an improvement or an increase in the acceptance of the vaccine treatments in terms of treatment adherence and in terms of patient satisfaction. But what trust means? In principle, it is the feeling or belief that one can have faith in or rely on someone or something. So it is, and also how can HTA help? First of all, by applying the definition, by analyzing the domains that I've said before. So it is the safety, the effectiveness, the cost, the social aspects, the environmental aspects, the legal and the organizational aspects. Also by promoting participation and avoiding mechanistic approaches to evidence-based deliberations. And what influences trust? Here are the factors affecting trust. On the one side, the patient's users of the health services across all sectors and levels of care, the individual healthcare provider and clinician, the institution providing healthcare and health system. So there could be trust at micro level, trust at macro level, and there are factors affecting to trust that could be related to. But mainly, there are two factors that affect to trust. First of all, data. And in the case of systems, not so if the patients need to pay, but it's cost. So I think those are the two main aspects, apart from obviously having some kind of beliefs around who is treating us and how they are treating us. So the belief on the healthcare systems and the belief on health professionals and the trust that we could have, it is based on the experience that we have had before. Also, social media are changing the world, and it is also applicable to precision medicine. And we are seeing the likelihood to trust or share information via social media from doctors, from hospitals, from health insurance, and from drug companies. Still, drug companies are the latest in terms of the sharing of information. We still have trust on doctors and hospitals, and they're likely to share information from doctors, hospitals, health insurance, and drug companies. But still, going from social media also is changing the way that we are approaching information and trust. Trust and healthcare systems. It is three main drivers of trust: the certainty on data, the certainty on cost, and the certainty of supply chain. Also, we have some uncertainties that are related to the experience that we have had before with some manufacturers or some companies. And also there is the trust in physician, the trust in technology, and the trust in how care providers uses the technologies. That is the combination of, in terms of creating trust. And that is applicable to precision medicine. In fact, where does or can the uncertainty lie? First of all, it is the context or perspective, that it could be internal. So it is the resources that we could have, the governance that we have, the stakeholders that are involved, and external, that is the framework, the legal framework that we have, the politics and the social value, the input or theoretical value of that it could be therapeutic or it could be economic. We have sent the two of them. So it is the uncertainty on the final effectiveness and the uncertainty that we could have in terms of the impact on cost that we could have. Also, how the deliberation process are done, how those technologies are implemented, and how they are communicated. In some occasions, some technologies fail in achieving the best results because it is not communicated in a good way to health professionals, to patients, to managers, and healthcare systems in general. Finally, how that can be applicable to precision medicine and healthcare? Well, by curiosity, we have, in terms of public procurement of innovation and innovative public procurement, we have two axes. On the one side, the value, and on the other side, the low and the low therapeutic or societal need. It is much more likely that when we have a high therapeutic or societal need and a high added value, that the therapeutic solution that we are going to apply, it is reimbursed or at least prepared to pay more if need very high. So that is if we go to this corner and at the right upside, we will see that it's more likely that we pay for something that has a higher value and a higher need. So it corresponds to a higher need. Here, then the problem would be, and that applies to precision medicine, what about the cost? So that is one of the things that perhaps could refrain us for reimbursing that. But if you go to low added value and low therapeutic need or low societal need, probably we will go to the left low side, in which we have no reimbursement. And then we have some, I would say, gray sides, in which there will be a high value, added value, but low societal or therapeutic need, in which reimbursement will be at equal cost. Or in some occasions in which we have a low added value, but high therapeutic or societal need, in which we can take some risk, and there will be possible reimbursement on the basis of other criteria. And in principle, it will be comparison to what we are doing as a standard of care. That's why there have been different kind of schemas in terms of introducing technologies in healthcare systems, especially when we have uncertainty on the value and uncertainty on the needs. And there have been so-called managed entry agreements or coverage with evidence agreements in some occasions. They could be financial and they could be performance-based. And that is applied also to precision medicine. In most of the cases, because of the uncertainty that we could have in the cost that the treatments could be applicable to individuals, we go normally to agreements that take into account the population level. It could be expenditure cap or price volume agreements. Probably you as pharmacists, you are accustomed to those, or at patient level volume or expenditure cap. Normally in precision medicine, it is much more applicable the patient level financial agreements. But it could be if the uncertainty is much more based on the performance, so it is on the evidence. Despite that is precision medicine, we go on patient level on what they have been called coverage with evidence developments, payment by result developments, or conditional treatment continuations as the main paradigm. In the past, most of those that were not related to precision medicine, they were the agreements that were obtained were at the population level, and they were coverage with evidence developments and payment by result, and as a whole, as the population that have the indication. Nowadays, we could drop down at the patient level in terms of producing coverage with evidence developments, payment by result, and conditional treatment continuations, or in terms of financial uncertainty, we could go volume or expenditure cap and free initial treatment. And that depends, once again, on which is the level of certainty that we could have with those new treatments that could be more precise, and which are the costs that are aimed by manufacturers in terms of doing so. So models currently under discussion, mortgages, so these new treatments, CAR-Ts, for example, that they are costing hundreds of thousands of euros, hundreds of thousands of dollars, and we cannot afford at the very beginning, because we are talking about a deferred payment, and we are talking about the possibility of paying along the lifespan of the patient that has been treated so far, or value-based schemas. Which is the rationale behind that? First of all, less cases, increasing life expectancy. And one of the things that I don't know if you are knowledgeable about, it is that most of the prices that are created in the world, they are not on the basis of the cost of developing the technology, the cost of developing the drug, but they are based on the willingness to pay by patients and the willingness to pay by systems of treating that technology. And that creates also attention. So it is not the cost of developing plus a margin, but the willingness to pay. And that's why, for example, there are technologies like gene and cell therapies that they are costing that high, or some, I would say, precision medicine solutions that are costing that high. But on the one side, it is in most occasions, and that is one debate by systems, it is that they consider that they are unjustified revenues. So continuing with the willingness to pay paradigm, it is not the best basis for sustainability in systems, and it creates also tensions, because there are huge revenues by companies that are not sufficiently justified by the value that we are obtaining in systems. Also, another thing under consideration, it is the treatment duration, especially in some areas like oncology or in cardiovascular diseases, in which nowadays we are chronifying some patients or many patients that in the past were dying in a short period of time. So which will be the treatment duration on the one side, and also who will pay for that? It is true that there are other opportunities that are created by far, but new treatments jumping in the arena, and that's reducing the cost by competitiveness. And also another tricky thing, it is that we don't know which will be the effectiveness at the mid-long term, and it is another fact that is also under discussion. So, are there ways to enable assessment of those precision medicine initiatives? Yes, but we will need data. We will need data. We will need good data. If we will apply precision medicine solutions, and we are not talking about biomarkers and then treatments, but we are talking about the combination of lifestyle, genetics, and behavior. We will need for sure good data, and there will be a need of the linkage of those data coming from different sources. Projects and trends in real-world data use. First of all, having good data locally. So another thing that is, especially when discussing with companies, it is that we will be in our healthcare systems good data, and that also increase the cost, because that needs and it requires to have a curation of the data. Also, it creates also another problem, that it needs a transformation and a structuring of the data in terms of allowing interoperability. It will be also the collection of issues and their prioritization. Nowadays, the projects that are moving in the world, it is going, instead of having a big data lake, it is to have good data locally and have federated analysis. So data federation, but it seems to be that it will be the new paradigm, and the analysis of joint results. So what we will be in the future, it is having good, we will be good data, we will be good local data, good data combination, and also good questions. Because finally, if we wanted to have the precise solutions, the precise technologies, we will be in need to have the good questions in terms of being answered by those technologies. I will refer to the current in terms of the interoperability paradigm. It has been created a standard in terms of combining data from different sources, and it has been created. I think it will be probably the standard of observational medical outcomes partnership, and it is the CDM. So it is the common data model, and OMOP, it will be something that enables systematic analysis of disparate observational databases that will be crucial in terms of enabling precision medicine. Which is the concept behind the approach of OMOP? It is that we need to transform the data obtained within different databases into a common format in terms of allowing interoperability. For that, we need a common representation of terminologies, vocabularies, and coding schemes, and then perform systematic analysis using a library of standard analytic routines that are based on the common format. So we are going to a common format that has been well described. I don't know if that will be the final standard. I do hope so, because it has been a huge effort in terms of reaching to this. And most of the organizations nowadays, they are using OMOP paradigm. OMOP, it is just changing the plaque. So this probably when you are traveling and you have in need to have different type of plaques, and there are some kind of universal plaques in terms of allowing that. And what is OMOP doing? It is transforming all those different plaque systems into just a universal plaque. There are also tools that enable transforming. So like White Rabbit, I wanted you to be familiar also with these technologies. White Rabbit in principle is a software tool to help prepare extraction transformational load into the common paradigm, that is the common data model, the OMOP. And the good thing is that even when we use different technologies and different CDM systems, we can combine them and make them interoperable, and then we can enable combining results from different sources. I will refer a little bit about Darwin. Darwin, it is the initiative from the regulator in Europe, from the European Medicine Agency. And the aim of Darwin, it is to offer a sustainable platform to access and analyze healthcare data from across the European Union in terms of reaching to real-world interrogation for making decisions on drug approval, in this case. So it is a way to faster approval of precision medicine solutions, especially drugs, by using data that is coming from different sources when there is still uncertainty when the drug is accessing to the market. And it will be a way also to have more certainties once the drug, for example, has received a conditional coverage approval. We need to consider that also although in some systems like the US, they are spending almost 20% of the gross domestic product in healthcare system, that is not manageable at the long term, and we are not obtaining the best results. So as you can see, United States is the first in terms of spending, and United States is below the mean in terms of life expectancy. And some of those that are doing a lower. Well, someone is saying, please zoom a screen. We can share the slides, so you will have the slides for you, and you will see that in principle it is United States the first in expenditure. Japan, it is not even in the first 5 countries in terms of expenditure, and then in terms of health results, in terms of life expectancy, it is the first one. Another example, it is my country, Spain, that is below the mean in terms of expenditure, and it is the second in terms of life expectancy right now. So, what about regulations and precision medicine? Nowadays, we are working on adaptive regulatory approvals, as you are seeing with the promotion of Darwin. When comparative arms are not possible, when there are small samples, and that will create a faster access to health technology. Furthermore, there are systems in and there are projects in terms of analyzing technologies that suppose a combination of different type of technologies. So it is when we need a combination of biomarkers, diagnostics, medical devices, and drugs, for example. And you can find much more in under the integrated HTA framework that allows you also to evaluate some of those complex technologies. And finally, we can do also the reimbursement of some technologies with the support in the generation of evidence, especially in areas where regulation is more lax. And this is the example of medical devices, that we can even grant the access to medical devices in our systems by creating more evidence after they have reached to the market. So there are some initiatives all around the world in terms of approving, for example, medical devices in this case, and I will refer also to drugs, and that is the case of Italy, in which they have applied already managed entry schemas in terms of authorizing faster some technologies, and also providing value-based value-based managed entry schemas in terms on the basis of results. So as you can see, it is not just the uncertainty on cost, it is not just the uncertainty on evidence, but we can create also some figures, and we can create also some initiatives in terms of allowing minimizing the risk by creating some kind of agreements, as we have described before, on the personal point of view. In which we have personal-based financial schemas, or uncertainty-based or evidence-based personal schemas, as we have seen before. And that is all for today. And I will be open to your questions. And we still have around 15 minutes for some questions. So as conclusions and some take-home messages. So we need to anticipate the future. Precision medicine will require a reorganization of healthcare services, and perhaps it is also a good way also to think about much more on prevention. So not just on treatment and treatment options. The context will need to be much more to be analyzed in profound. Public-private partnership will require public-private partnership, especially if we require diagnostics and prevention and data storage of certain things that will allow us also be more precise in the treatments that we are applying. It will require also data storage and protection. It will require health literacy on the side of professionals, but on the side of the citizens in general. It will change also the role of health professionals and citizens. Health professionals will be much more the advisors, but citizens will need to play a higher role. Also, it will change also the role of manufacturers, especially in therapeutic and diagnostic lines, and it is already there. So nowadays there are companies that are purchasing also diagnostic drug companies that are nowadays purchasing diagnostic companies, because the only way of introducing their solutions into systems require the diagnostics. And also there are still many uncertainties in the case of therapeutics, and which will be the mid-long term of some solutions that are nowadays we are putting as personalized medicine. And that's all. If you wanted to learn more, here it is the HTAI 2023, and we will discuss about advanced therapies and personalized medicine and precision medicine in one of the plenaries in which I will be involved. And you can go to Adelaide in June and discuss about that and learn more about the HTA approach. And thank you very much, and it is all from my side, and I'm waiting for your questions.
Thank you very much, Inaki. Now we can move on to the Q&A. So just to repeat again, for those of you who missed, just please use the Q&A tool to propose questions if you have any. And we have about 10 minutes to get through this. So maybe we can start actually with one question, which is already in the Q&A box about how likely is a variation in ethnicity to impact basically precision medicine going forward? And would there be a way to overcome this from a health technology assessment perspective and ensure that new treatments take this into consideration?
It is a very good question, and in fact we have discussed so far, and perhaps in countries in which the ethnic variety is not that high as it is in Europe, although we have more and more migrants and the representation is right now higher, but it's a huge problem in some countries. I will explain. Well, I would talk a little bit about the experience of our colleagues in Singapore, in which they have very different ethnic and huge variability and they have issues when discussing, for example, drugs and drug introduction, because most of the treatments that they receive in Singapore, they have been produced in high-income countries, especially in the US and Europe, and they don't have the combination that we have in especially with Caucasian populations and also Afro-American. In the case of Singapore, mostly they are Chinese and Malaysians and also Indians. So it is. And they need to refer, and in most cases, what they do, it is what they say conditional coverage solutions, and they need to produce real world data in terms of making the final decision. So when we are saying that it is trial and error, in the case of Singapore, it is a mild case. And also in the case of drug is massive, and I think it is perhaps it is good also to hear the voice of our colleagues in Singapore, because they have finalized with, I think, good solutions, as I said, especially creating a good data on real world data evidence.
Excellent, thank you. So another question which was asked is from Nuna El Bizri is, to your knowledge, which lower middle income countries outside of Europe has incorporated the application of precision medicine in their treatment portfolio based on HTA recommendation and decision? And which party pair is likely to be paying for this HTA entity?
Well, there are some countries, especially in Asia Pacific, that they have introduced so far. So they are using that. I would refer to Cambodia and Vietnam, that they have some HTA systems that they have used in terms of analyzing those schemas, and they have said they have been very useful in terms of making decisions and in terms of making, well, in terms of enabling discussions with manufacturers, I would say. So they were convinced about their solutions, but they were not convinced about the prices that were offered by companies. So so the basis of what we have discussed so far, so the different domains and which could be the value, have served them in terms of discussing with companies around the fair price for the countries.
Okay, thank you very much. And there was a related question then on what is the main condition to success for implementation of this in low middle income countries?
I think probably one of the things it is establishing good priorities. And I think one of the challenges right now it is that we think about low and middle income countries as if they were high income countries in terms not in terms of budget, but in terms of which their needs are. And I've seen in many occasions that we are sending solutions that they are not solving their problems. And probably if I would be working in a low and middle income countries, which I've done in the past, it is to establish which the main needs they have and how that could be covered with health technologies, and not starting from the health technology, but starting from the health needs. that probably will diminish some of the tensions. I know that it is complicated in some occasions because they will receive offers from different parts of the world, and probably most of those will come from manufacturers that are mostly feeding the market in high-income countries. But probably concentrating on which the health needs are and prioritizing on which areas they will obtain best value for money, that will be the area and the way of doing.
Great, thanks. Yeah, certainly a difficult but important challenge.
We are not solving the world.
Yeah, but one maybe last question to finish on, and I think this is a nice question to finish on, is like, what are some practical steps that I could take to promote precision medicine, or maybe just in the context of this talk, promote cost-effective precision medicine in my community as a pharmacist, and how can I spread awareness on this?
I think creating good data. So it is helping creating good data. So probably you will have databases on results and databases on prescriptions. So having good data locally, I think it is crucial, because that will help also providers and healthcare systems promoting more precision medicine, because the combination of those data with finally with the outcomes that will allow us having better decisions. So probably promoting databases, promoting real world data storages and so on. I think it is crucial, because as Edward Denning was saying, without data you are just another person with an opinion, and it is true. I think we need to try to diminish the decisions that are made on I think that. I think it is no, I have the data. So and on that basis, probably it is not the as we have said before. So it is that requires a combination of data coming from different sources. But at least it will be much better than thoughts or beliefs. Yep.
Great, thanks very much. Yeah, since pharmacists are in such frequent contact with patients, I think they're also in a good position to gather such data. Okay, but just in the interest of time, unfortunately, we already have to move on to closing. So let's just reshare my screen one moment. Yeah, so we just have last couple of announcements before we finish. So registration and abstract submission for the FIP's 81st World Congress in Brisbane, Australia is now open. You can submit your abstract before May 1st and register before 15th of June for the special early bird fee. And you can find more information about the Congress on the website brisbane2023.fip.org. Lastly, you can check all future FIP digital events here, events.fip.org. Hopefully we will have an opportunity for more events on precision medicine, but there's a huge wide range of topics that you can find events on. So I'd really encourage you to check that out. And lastly, but not least, I would really like to thank you all for attending. I would also really like to thank our guests today. So Professor Iñaki Gutierrez Ibarluzia, and also my co-organizer for this event, Professor Stephanie Wang, as well as several members of FIP who have helped to make this happen, including Azu Selsvik and Susanna Costanova. And with that, we will close and hope to see you all soon.
Yeah, thanks all, and thanks for the invitation. Much appreciated.